House File 4142, I guess you get to sit in the hot seat again there, Representative Nadeau. Would you like to have this bill moved in front of our committee?
Yes, please.
Okay, we have House File 4142 will be laid over. We have the bill before us. Our goal is to be done with this bill roughly at 2:07. So with that, it's yours. We got 6 testifiers too, so go ahead, Representative Nadeau.
Thank you, Mr. Chair and members. This bill is far more fun than the previous one. So this is about GLP-1s. So GLP-1 drugs were originally developed, remember, to help people with type 2 diabetes manage blood sugar levels, but they've gained widespread attention for their effectiveness as a treatment for obesity. Due to their cost, however, coverage of GLP-1s for obesity treatment in Medicaid, in the ACA marketplace, and most large employer firms remains limited. And GLP-1 coverage in Medicare for treatment of obesity remains prohibited under current law. Obesity drug coverage in Medicaid remains limited, and Minnesota is one of 13 states where Medicaid programs cover GLP-1s for obesity treatment under fee-for-service as of January 2026. When covered, GLP-1s are typically subject to utilization controls such as prior authorization, which can further limit access. Notably, Kaiser's 2025 Medicaid budget survey found 16 state Medicaid programs covered GLP-1s for obesity treatment as of October 2025. However, since then, 4 states, California, New Hampshire, Pennsylvania, and South Carolina, have eliminated coverage for GLP-1s for obesity treatment, likely reflecting the recent state budget challenges and the significant costs associated with this coverage. Medicaid spending on GLP-1s has grown exponentially over the last 5 years, reflecting both an increase in its usage and expanded coverage in many states. This figure includes expenditures on both obesity-indicated GLP-1s and type 2 diabetes indicated GLP-1s prescribed to patients with an obesity diagnosis. In January of 2020, spending on Ozempic, type 2 diabetes indicated GLP-1, was just $4.6 million. At that time, Wegovy hadn't even been introduced. By January of 24, monthly Medicaid spending on Wegovy alone exceeded $51 million, and by October 24, it had grown to $192 million. In Minnesota, the 2024 Medicaid assistant trends for GLP-1s specific to weight loss ranged from 100% to as high as 700%, depending on the program, with an even higher trend seen in the first 3 months of 2025. The average annual cost per patient for GLP-1 treatment is $12,000, with total expenditures now representing more than 12% of Minnesota's overall pharmaceutical costs. In 2021, the legislature removed the weight loss restriction from the drug formulary. At that time, the fiscal note estimated that the cost to DHS would be $1.268 million for FY 24-25. $1.268 million. It's far above that now, and we continue, we've requested fiscal notes from the department, both not just on the spending, but also on the corresponding rebates amounts, but we're still waiting for those. But what we do know is that according to MMB, in the 2025 managed care, the 2025 managed care amendments for rapidly growing utilization and cost trends have totaled for 24-25, just the amendments for the increase was $11.7 million in 24-25, $78.7 million in 26-27, and $87 million in 28 and 29. Members, my bill is not about a discussion whether or not obesity is a chronic disease and condition that needs to be treated. That's not what this is about. This is about balancing or trying to balance the costs of our healthcare system with a very, very increasing cost trend on certain drugs. And this isn't anything new. We currently restrict occupational and physical therapy to kids, to adults under the age of 20. Last year, the governor cut chiropractic care completely out of managed care. And I'm not trying to say that one is comparable to the other. I'm just saying that we do these things in an effort to manage costs. This happens to be a significant cost and a growing trend that I think we need to discuss. We need to understand it. We need to know how much the spend and trend is, and we need to have a more thorough understanding of the corresponding rebates that we're getting for these drugs. And with that, I would love to hear from testifiers, Mr. Chair.
Thank you. We have 5 on Zoom. First one on Zoom, 90 seconds. We have Claudia Fox, and then after Claudia Fox is Carolyn Bramdett. So Claudia, you're on deck. You're on the floor.
Great. Good afternoon, Chairman, members of the committee. I'm Dr. Claudia Fox. I'm a professor of pediatrics and co-director of the Center for Pediatric Obesity Medicine at the University of Minnesota. I've been treating children with obesity for the past 20 years. I'm here to urge you to reject the proposed Medicaid changes to the Medicaid formulary that would prohibit coverage of obesity medications. We must be clear, obesity is not a choice. It's not due to low willpower or poor parenting. It's a chronic biological disease of metabolism. Consider my patient Derek. At age 14, he weighed 270 pounds and already had diabetes and suffered from depression and bullying. Without intervention, Derek faced a lifetime of isolation, dialysis, and heart disease and early death. We started him on a GLP-1, which is standard clinical practice as recommended by the American Academy of Pediatrics.
30-second warning.
He lost 57 pounds and his diabetes test normalized. However, insurance paused coverage and he regained 20 pounds in just 3 months. This is the nature of a chronic disease. When you stop the medicine, the disease recurs. Denying coverage of obesity medications is a parity issue. For example, you wouldn't stop covering chemotherapy for patients who have cancer. To treat obesity as a matter of vanity or fault ignores decades of scientific evidence. I acknowledge that the cost of these medications are high, but the cost of untreated obesity will be higher. I urge you to use your powerful voice to negotiate better prices with drug companies and PBMs rather than forcing your constituents to lose evidence-based health care. Thank you.
Okay, thank you. We have Carolyn Bramdett, and then right after that will be Aaron Kelly.
Thank you. I'm Carolyn Bramante. I'm a general internist and specialize in obesity medicine. I see adult patients at the University of Minnesota. I'm also here to urge you to reject the proposed changes to the Medicaid formulary that would prohibit costs of GLP-1s for treating obesity. And we have other less costly medications for obesity as well. So we don't want to not cover any of them. It's easier to assess the short-term cost savings in adults because they have more costly events. So a recent paper in the Journal of the American Academy of Cardiology used select clinical trial criteria to analyze real-world data. They found that because treatment with Wegovy prevents 20% of heart attacks, treating just 49 patients for 5 years prevents 1 heart attack or stroke. So that's a cost of about $24,000 to prevent 1 heart attack. The cost in Minnesota to insurers of 1 heart attack
30-second warning.
are much higher, $29,000 for just the inpatient care of the acute heart attack, $66,000 for bypass surgery. Lifetime cost is over $140,000. So we are looking at an immediate cost savings of about $63,000, not even considering beyond that first year after the heart attack. So and this is likely an underestimate of cost savings because that is just one outcome. Treating obesity improves other costly and more common medical conditions like osteoarthritis. So we will probably be saving our state money if we continue to cover obesity treatments and allow doctors to decide the dosing of those treatments for their patients. We often want to use a lower dose, but sometimes insurance doesn't allow that.
Thank you. Aaron Kelly, and then after Aaron Kelly will be Matt Prokop. Aaron.
Thank you, Mr. Chair and committee members. My name is Dr. Aaron Kelly. I'm a professor of pediatrics at the University of Minnesota, where I co-direct the Center for Pediatric Obesity Medicine. I'm a researcher, a clinical trialist, and I'm a leading expert in obesity medications. Obesity is ground zero for countless other health consequences. I could spend 90 minutes talking about them. I won't. High blood pressure, high cholesterol, type 2 diabetes, heart disease, and heart failure. Very expensive diseases to manage. Cancer, sleep apnea, osteoarthritis, kidney disease, liver disease, lower quality of life. These medications do more than just hitting two birds with one stone. It's two birds hitting 100 stones here. We are able to target other diseases and prevent other chronic diseases from emerging. Having led some of the clinical trials, I can tell you that in the studies that we've done,
30-second warning.
medications, we take them away, things come roaring back. The weight comes back, blood pressure comes back, cholesterol comes back, all of these things with veracity. We don't want to be part of a group of states that offered these medications and then took them away. It's devastating for patients. We're better than that. We can find ways to make this work. So I urge you to vote no on this bill.
Thank you. We now have Matt Prokop, and then after that will be Mally Callahan.
Good afternoon, Mr. Chair and members of the committee. My name is Matt Prokop, and I am the Director of State Government Affairs for the American Diabetes Association. The ADA supports comprehensive coverage for obesity treatments, which include access to FDA-approved obesity medications. And as such, we appreciate the opportunity to provide testimony in opposition of House File 4142. Obesity is a costly chronic condition. New data from the ADA shows that obesity increases annual Medicaid costs by approximately $3,800 per person, translating to more than $56 billion in additional annual healthcare expenditures. Treating obesity early can prevent costly health complications and save the state money, especially in our most vulnerable populations like Minnesotans who have Medicaid coverage. The ADA's January 2026 journal article on the costs and benefits of treating obesity among adults and Medicaid include the following positive outcomes for those who have access to obesity
30-second warning.
treatments. $997 million in direct medical cost savings, $874 million in productivity gains, $7 billion in quality of life improvements, and $11.8 billion in mortality reduction value. Reducing coverage that is already available to Medicaid beneficiaries is a step backward, increasing risk for complications and increasing medical costs. As with diabetes, individuals with obesity deserve access to evidence-based treatments that can help improve their health and ultimately drive down healthcare costs. Thank you for your time and consideration, and we respectfully ask the committee to oppose House File 4142. Thank you.
Thank you there. Next is Mally Callahan, and then in person, I understand we have our last testifier is Natalie Eichmann.
Great. Thank you, Mr. Chairman and members of the committee. I'm here on behalf of the Diabetes Patient Advocacy Coalition, or DPAC, an alliance of people working together to support public policy initiatives to improve the lives of people living with and at risk for diabetes and its complications. It's our goal to ensure quality of and access to care, devices, and medications for our community, which include anti-obesity medications, because access to effective obesity therapies is crucial to effectively prevent diabetes. When coverage is cut off, patients don't just lose a drug, they lose a chance to prevent a lifelong, costly disease and its complications. Coverage of these drugs can treat obesity and prevent over 200 comorbidities that are not only expensive to the state, but detrimental to the health, productivity, and quality of life of Minnesotans. We urge you to oppose HF 4142
30-second warning.
and protect access to these preventative, life-changing treatments. Thank you for your time.
And I was wrong, Natalie is also on Zoom. So Natalie Eichmann, you are our last signed up testifier.
Thank you. My name is Natalie Eichman, and I am a board-certified obesity medicine physician assistant practicing here at Body Weight Loss in Minnesota. I'm also the president of the Minnesota Obesity Society, and I am here to respectfully oppose number 4142. Obesity is not a lifestyle choice. It is a chronic, relapsing, multifactorial disease recognized by every major medical organization. It is driven by complex interactions among genetics, biology, environment, and social determinants of health. Left untreated, it significantly increases the risk of diabetes, heart attack, stroke, and cancer. I care for patients who have struggled with this disease for years, often decades. Many have tried repeated lifestyle interventions with limited success, not due to lack of effort, but because their physiology actively resists sustained weight loss, which is part of the disease. Modern anti-obesity medications like GLP-1s are evidence-based, FDA-approved treatments that target the biological mechanisms underlying the
30-second
disease.
warning.
The problem with obesity is that it is one of the few diseases you can see. It used to be considered cosmetic, but now we know better. These medications are not cosmetic. They are medically necessary and life-changing. If this passes, it would effectively deny access to the most effective treatment for some of our most vulnerable patients. We would never consider withholding treatment for other chronic diseases based on outdated assumptions about personal responsibility. This bill reinforces stigma and creates a two-tiered system where only those who can pay out of pocket can access care, thus widening disparities. I urge you to consider the science, the clinical reality, and the lived experiences of patients. Obesity deserves the same standard of care as any other chronic disease. I respectfully ask you to oppose number 4142. Thank you.
Okay, we have Co-Chair Bierman. You are first on deck.
Thank you, Mr. Chair. Thank you, Representative Nadeau. I just had a question on, as we just heard from a number of testifiers, there's a lot of conditions that weight has, an impact on. And so I was just looking, if it's just solely for weight loss, how much is there an estimate of what we would actually save? Because there's so many commingling conditions that go along with that weight. Doctors would have some latitude in what they're prescribing for around that. Do you have any data on that?
Representative Nadeau.
Yeah, thank you, Mr. Chair. And Representative Bierman, or Chair Bierman, that's a great question. And that's hopefully the information that we're going to get with the, with the technical assistance and the fiscal note on this bill. And you're right, there's all the medical exclusions are still there. This is a carve out solely just for weight loss. So our pediatrician friends and our doctor friends that are using GLP-1s to help people with comorbidities, they're still going to be able to do those things. This is merely solely just for weight loss alone.
Okay.
Mr. Chair, thank you. Thank you for that response, and I'm glad we have a fiscal note coming. I can't believe we don't have a fiscal note, though.
Okay. Members, this is
Joke for you.
Members, this is going to be laid over. We have four more members. Four more members on. That's what I'm going to limit it to. So Representative Bonner, you're next, and then Representative Hewitt.
Thank you, Mr. Chair, and thank you to the author. I'm going to respectfully disagree. I think we often talk about prevention as the ultimate here, not only in terms of quality of life, but in terms of the expenses that follow. Because what we're basically saying in this bill is that we're going to wait until you get sick. We're going to wait until you have a whole list of comorbidities, and then we'll let you lose weight. When we could just have you lose weight on the front end, prevent those comorbidities, prevent the additional expenses, give you a better quality of life, and that makes literally no sense. In terms of savings here, we're talking about anywhere between a 5 to 25% body weight reduction can have severe or incredible changes. It can lower the needs for other medications. It can create fewer doctor visits, decrease hospitalization in areas like arthritis, heart disease, diabetes, diabetes alone. it can save, by having these, the ability to do this, you can save up to $5,800 a year on that alone. I think there's a much larger picture here, and there are numerous articles, which I'm sorry I did not bring them with me today, but that are out there that talk about how we are rethinking GLP-1s and their usage because of their ability to prevent all of these other comorbidities down the line. And so I think this bill, while well-intentioned, is extremely short-sighted, and therefore I could not support it.
Okay. Representative Hewitt.
Thank you, Mr. Chair, and thank you, Representative Nadeau. I see where you're going with this, but it's very personal to me. There isn't one of my friends here in the legislature, both sides of the aisle, that haven't asked me what happened to you. Literally, I dropped 90 pounds within 9 months, including my doctor thought I was sick, but I was not. It was a direct result of these medications. Since I've been on these medications, I have no longer taken injectable insulin, which I know saves my insurance company and me quite a substantial sum every month. I know that the factors of going to the doctor and all those things that we heard about, I don't have to reiterate them, are true. I'm a living example of the scientific side of these drugs. And I think that even if you look at these fiscally, the state should really look at investing in these because they're going to keep people in the state that I was in. At 30 years old, when we had our second child, I was in the middle of my physical, and my doctor and I were basically planning out the rest of my life. And the chair knows this, people that drive or work in ambulances don't get a lot of time to eat full dinners or special foods. You eat what you can, and the weight was continuing to come on, and we tried different ways to get rid of it. The doctor clearly told me, John, I can see you seeing the 2 boys graduate from high school, but beyond that, I just don't see it. You will not see your grandchildren. That's extremely personal to me because the changes I made in my life and the changes my care team did for me are now going to allow me to see a grandchild in September. And so that's my personal side, and I don't expect everybody to react to my personal side, but it is my story. But I can see this being just for money and investment reasons for the state, that we should make sure that if a physician, again, not everybody is eligible for this. My son was just turned down, and he has borderline diabetes. And he was turned down, he has insurance and stuff, but he was turned down because he did not meet the requirement. So if we have knowledgeable physicians that are subscribing this, that really feel that this is going to best fit them, I don't know why we would want to limit this and not make this part of our formulary. Thank you, Mr. Chair.
Vice Chair Ryer.
Thank you, Chair Backer. I just have a couple questions. One is, I keep reading articles that as the market advances, we're seeing oral versions and the costs are going down. Have you tracked the per-person cost of administering or receiving this? Because I want to know, I guess before I would have an opinion, whether or not those costs are coming down enough that maybe the data that we're looking at that's retrospective is a bit out of date.
Thank you, Mr. Chair.
Nadeau.
Representative Ryer, that's a great question. It's one of the things that the current president is working on with Lilly and others to put it on his Trump RX, website. And so, yes, I do believe those costs are going to continue to go down. But I think, and one of the biggest reasons that I'm doing this is to make sure that once things get put on PDLs, we lose track of where those costs are, like completely. And so all of a sudden you can have a $5,000 drug and it's got a $10,000 rebate, and so it's and again and thank you, Representative Hewitt. I'm sorry I don't mean to cross these things, but I love those stories. Those are important stories. These are important things to do. But I feel like our job is to be as smart as we can about the overall system that we're funding. And we've talked a little bit about the challenges that the hospitals have. So, but back to the specific question, yes, I think those costs are going down, and anecdotally, I think that we're seeing those go down.
Okay, follow-up?
Thank you. Yes, and kind of going to Representative Hewitt's experience and so many other people, my understanding is that people who stop taking the medication then tend to go back to their original well-being. So I like to make sure we've got processes thought through and implications mapped out. So I was just picturing someone who received the GLP-1s as within your framework because they had comorbidities, they were eligible, they got them, and then they lost the weight, didn't have comorbidities anymore. Are they all of a sudden not eligible, and then they get onto a yo-yo thing? What happens to a person who has achieved a higher level of health because of this?
Representative Nadeau.
Yeah, and thank you, and thank you, Representative Ryer. And I'm not obviously a practitioner, so I don't think I can answer that question. But it's part of the reason that I brought this bill. People that go on GLP-1s, if they go, they're on them forever. And if we look at the cost trends of that, and I think that's what I'm trying to look at is, I mean, how much can we afford? How much can we afford? And again, I'm not trying to pick winners and losers. How much can we afford? How much can our system afford? So it's a great question. I don't know the answer to it. This is a system that, I mean, every day we're making, they're making huge breakthroughs in some of these things. And who knows, in 3 years, these GLP-1s might be a penny. And they're all oral, and it's great, and it's no big deal. Who knows? But right now, when I look at MMB's thing, and we're seeing the amendments to just our managed care going from what was once considered to be 1.2 million to north of 90 million. That's something I think we should at least acknowledge and try to address. Try.
Okay.
So, Chair Backer, one more follow-up, please. I don't think that answers the question, but we have all these, it was deferred to a practitioner, and we have all these practitioners on Zoom who might be put in a position of having to, forgive me, take your medicine away. I would like to know what they would do because it's a public policy implication. It's not a nice to know, it's a public policy implication on how we are going to handle the impact of the drugs being prescribed to someone.
Nadeau, any comment on that?
No, I think that as time goes on, we had a lot of testifiers talk about, the reduction in heart attacks. We heard, health outcomes, reductions in heart disease, liver disease. One thing that we do know is that 74% of Americans are obese or overweight. We know that. 53% of kids. 18% of 18-year-olds have fatty liver tissue disease. This is not something that's going to go away, and I don't think we can legislate our way out of there, but I think our job is to try to listen and engage, and that's why this bill is being laid over, and we're going to try to, find out what can we afford. We'll get the numbers back, and if it's something that we can address or should address with, with consultation. I've had numerous conversations with U of M docs on this, and they don't love this bill, by the way, but. It's, their job is to treat kids. Our job is to pay. And if we consume all of our spending in one area, I think we should understand why and how, because this is one component of the challenge that our healthcare system has today. This is one component. That's all.
Okay. A lot of passion with this. We do have other important bills on the agenda. This bill is being laid over.